Everybody knows that obesity is our most expensive health problem, and strikingly what we currently use to evaluate obesity is a mathematical equation, BMI. I kind of think of it sort of like if we were to continue to taste urine rather than do hemoglobin A1C for diabetes. So why do we want to know a better method of managing obesity? We want to know a better method because we have to reduce the amount of Americans that have obesity for their comorbid diseases, for their depression that's associated with it. Obesity shrinks the brain even more than the normal amount of shrinkage with MRI. Obesity increases virtually every type of aging. Obesity and aging in some ways are the number two factors that are ignored. So when a cardiologist sees a patient with heart disease, he frequently doesn't put it in the context of aging or the patient's weight, or depression is not put into the context of brain shrinkage and loss of neurogenesis, or a patient's weight is not put in the context. So this actually interferes with a holistic or A4M type approach. By controlling leptin, or lowering leptin and breaking leptin resistance, we are now, according to a recent study in New England Journal that came out literally about a month ago, that leptin lowering was the best correlation or a top correlation with fat loss, obesity control. By controlling the accumulation in fat, we not only slow down aging, but we improve human performance. So we all want to have quality of life as we get older. We want to have better performance, physical performance. To do that, we have to have a low leptin value and not be leptin resistant. Your brain controls eating, and it's in a dynamic relationship with an organ, which I call, I guess you could call it adipose tissue, is a giant organ, sort of like skin. And the brain communicates with these fat cells through a little leprechaun, better known as a leptin protein. And as you change your leptin, you change your body fat, and you change your entire aging. Now, every disease that we've tackled in medicine and that we've made progress has core markers. In fact, those core markers are more than just blood pressure as a stroke predictor. We now look very carefully at MRIs and MRAs and see microstroke occurring, such that we now know that having an elevated blood pressure is a marker of almost like being a boxer, where your brain is pounded slowly into small microstroke prior to big strokes and big heart attacks. We know that ejection fraction is one of the core markers on the echocardiogram of heart failure patients. We start to look at ejection fraction at 50% and start to panic and try to lower it. We like to watch LDL very carefully, and these patients that we now do MRI and MRA and see atrophy of the brain and microstroke and broken blood vessels and coronary calcium buildup in the heart, we know that we can get a better result if we're more strict at that point with an LDL under 70 and an HDL as high as we can get it. We know that diabetes has changed a lot in its diagnosis, from sipping urine as a guesstimate test to a fasting blood sugar as a guesstimate to hemoglobin A1C. I've watched hemoglobin A1C change. Hemoglobin A1C used to be diabetic at 7, now it's 6.5. Pre-diabetics are at 5.7, depending on your view, 5.7 to 6, 5.7 to 6.5. But we have a marker. Liver enzymes. I had a patient with fatty liver recently, and he was searched all over his body for other causes. Turned out his main cause was lifelong growth hormone deficiency and a little bit of alcohol combination. But we knew to follow his liver disease with liver enzymes. We knew to look at ratios. We knew to fractionate alkaline phosphatase. We had specific information. We know with osteoporosis, more bone densities are broken. With osteopenia, we know that a -1 bone density counts for something. A +2 bone density can be osteoarthritis, but much greater reduction in broken bones. We have an entire strategy to change the bone density, everything from strontium, vitamin D, Forteo, and various medications. In fact, we do this with every illness when it comes down to it. We look at microalbumin and kidney disease. When I first went to medical review boards and things, they wanted us to do wanted to know what an eGFR equation was. They didn't know that you could measure GFR in an equation. And now it's done routinely. GFR for kidney function is done. When I first started in medical school, there was a big emphasis on TRH stimulation tests, but now we all have TSH as the best marker, and the TSH has changed from 10 to 5 to 3 to 2.5. Most doctors don't even remember parathyroid as a therapeutic agent. But now we realize that parathyroid goes up with age, and doctors say that we need to keep parathyroid levels at 35 rather than 70 prior to developing secondary hyperparathyroidism due to osteoporosis. Now, all this is great, but the number one most expensive disease or problem in the United States is a multifactorial illness called obesity, which is associated with depression, sleep disorder, sleep apnea, cardiac problems, medical problems of all types. Where is our marker? The answer, I hope to convince you, at least partially today, is in doing leptin levels. The measurement of leptin levels will be as key to dealing with obesity, in my view, as any of those other markers I just showed you or talked about. The reason why is that obesity signals the brain, leptin signals the brain to decrease its food intake. And adipose tissue shoots some of this leptin back to the brain. Unfortunately, cortisol somehow binds into that leptin and prevents it from going into the brain. And more leptin circulates in the blood, and a cortisol hyperleptinemic state exists. And all you do is keep eating calories and gaining weight.